And we're pleased to have Dr. Moran back. He's the medical director of the Cardiac Wellness and Advanced Lipid Management Program and assistant professor of medicine at University of California, San Francisco. Dr. Moran, thanks for coming back. I appreciate it.
My pleasure. My pleasure. I hope I don't have to get to talk with you in my face here. Get two slides up. I said the mic. Can you hear me? Is it mic's working? Here we go. We got some slides. As it was explained, I'm a lipidologist. I've been running a lipid clinic for the last 18 years, and pretty much primary prevention has been our goal. And what's happened recently is the American College, American Heart Association have brought out some recommendations and kind of thrown the lipid world into a tizzy because there's some real major changes that they've made. So let's take a look at this. We're going to talk about the background of where these came from, the risk profiling methods that they've now proposed. What are the goals of therapy with these new recommendations? Who are the groups to treat with statins? What about non-statin use? And a reasonable compromise, because as you're going to see, you might not agree with some of these new recommendations. And then some other major concerns about these recommendations. So background. We know that the National Heart, Lung, and Blood Institute back in the 1980s put together a group called the National Cholesterol Education Panel. And they came up with guidelines for lipid management. We had some in 1988, 1993, 2001. Those were the last real full recommendations. And in 2004, they kind of cleaned up a few loose ends there. And then it's been a long time now since those last recommendations. As you can see, there have been a number of other groups that have come out with their recommendations. So finally we heard that the new ones were coming out. We thought this is great. It'll kind of really solidify the field, get us pointed in the right direction. And so out came these recommendations in November. Now the concept you have to understand. What they did was the National Heart, Lung, Blood Institute, they said, you know, we are just going to take randomized control data, and that's all we're going to use to make our recommendations, which at first sounds pretty good. We're really getting this solid evidence-based medicine. And they went ahead, put all this stuff together. It took about 4 years to look over all this stuff, come up with their conclusions. Then they asked the American Heart and the American College to take this and make recommendations from this data. They decided they were no longer in the guidelines business. Well, one of the problems and big concerns has been if we take a look at what is evidence-based medicine, and this definition from the British Medical Journal, the conscientious, explicit, and judicious use of current best evidence in making decisions. So randomized control trials are not the current best evidence. There's all sorts of things. We've got epidemiological and observational data, lab and animal data, post hoc analysis, non-randomized trials, genetic trials, expert opinion. All of these things go together to make current best evidence. You can't just take randomized controls only because they don't look at everything. So, in terms of the risk profiling, how many people risk profile your patient before you start them on a statin? Using Framingham or Reynolds risk. How many people? Okay, it's kind of interesting because the reality is you have to have some way to risk profile these people. The old idea about flip a coin, if it's heads, I'll treat, if it's tails, I won't. We have to kind of move on to be more specific because we don't want to undertreat, we don't want to overtreat. And that's the whole idea of risk profiling, trying to pick out who's at high risk, make sure you treat them aggressively, who's at low risk, don't treat them. So let's take a look at the methods we have. We've got the Framingham risk score, the Reynolds risk score, and the new one, which is called the pooled cohort equations, which we'll talk about. Now, Framingham risk, if you're somebody that uses Framingham risk and you're real comfortable with it, well, let me shake you up a little bit. These are called receiver operator curves or ROC curves. And if you notice let's see, there we go. If you notice this line right here, this is the line of chance, meaning whatever happened was by chance alone. And as it moves up here, it means that your test is more specific, more sensitive. The farther it moves, the better the test is. And so using that data, you can get what's called predictive accuracy. How accurate is your test in prediction? So let's take a look applying Framingham data to a number of populations. Let's start with Framingham. In men, it's fair, and women, it's good as a predictor. New York, it's a poor predictor. Honolulu, fair predictor. Physicians Public Health, poor predictor. Cardiovascular Health Study, men and women, poor predictor. So Framingham's got a lot of major problems with it. Remember, it's an all-white population on the East Coast back in the days when our lipid problem was an elevated LDL. That's not our lipid problem anymore. Now it's high triglyceride, low HDL, and LDL with small dense particles. So, Reynolds risk score. Reynolds risk score came up because they said we need a better thing than Framingham, and they came up with this. And people have said this is more accurate than Framingham in women. That was the main goal, but it turns out also in men it's more accurate. And if you haven't seen this, you can go online. It's pretty nifty. You can see, you go online, this comes up. You fill in all these various boxes here and then calculate your 10-year risk. Now, how's this different than Framingham? It's different because they have two things, an HSCRP, and you put in family history. And then what's nice is when you hit the 10-year risk calculation, you come up with something that looks like this, and you can print it out and give it to the patient. And notice it talks about what your 10-year risk is 15% in this individual. But then what they show you is if I didn't smoke, I drop my risk to 7. If my blood pressure was 120, my risk is 6%, yada, yada. And we get to the bottom, if all of those were optimal, my risk is only 1%. So the patient's able to see what they can accomplish with therapy. Now the new one is the pooled cohort equations. And the idea was they decided we needed a new risk score. We knew that Framingham had trouble, Reynolds risk was a little better, but still trouble. So they came up with this. It's very similar to Framingham risk. A couple things they add is race, and they add if you're diabetic or not. They use some different populations to get their data from and make their conclusions. And primarily now it's just for African Americans and non-Hispanic whites, because that's the groups that they looked at. And it's got an interesting concept, which I like. The intensity of treatment is based on risk, not the lipids. I hope that when you finish today, you're going to realize that a lipid profile doesn't help you much at all in terms of risk, as you're going to see. And you want to be basing people on what their risk is, not just looking at LDL and saying, oh, it's good, it doesn't need to be treated. Oh, it's high, I better treat it. The problem with this new one is it can overestimate risk by as much as 75 to 150%. You haven't even heard the really good news here. So this is NHANES. NHANES is an observational data gathering. And so what they've done here is we've said, okay, who needs statin therapy? We're going to look at ages 40 to 59. The ATP3, that was the old Framingham, and now here's the new ones. And you can see between 40 and 49, not a big difference in who's recommended to be treated. But look what happens when you hit the 60 to 75 range. Men go from 30% needing statin to 87%. Women go from 21% to 54%. So people are a little concerned about this. And then we've got a study out of the Netherlands, the Rotterdam study, 4,800 patients, observational study. And they said, okay, let's use the different guidelines. Let's use the ATP3, let's use the European cardiac guidelines, and let's use the new ACC-HA guidelines. And just if we look at the men, 52% should be treated with statin according to ATP3. Our new ones now, 96% of men. And women have gone from 36 to 66. So it's almost everybody needs to be on a statin. And this really isn't what we want to be doing. And their conclusion, which I would totally agree, we need improved risk predictors. So What about the non-invasive test? Now remember this, what I'm talking about here, this is the new guidelines. Non-invasive tests. Their comment is they show some clinical promise, but realize none of these new non-invasive tests, such as CRP and things like that, have had randomized controlled trials to show reduction in cardiac events by using them. And if they didn't fit into that, they didn't look at them, they didn't make any conclusions. But obviously, family history of early heart disease, CRP, coronary artery calcium score, ankle brachial index, these are all things which can be very helpful in risk profiling somebody. And then of uncertain value were these. Now look at GFR. GFR is of uncertain value. GFR, your renal function correlates very closely with risk for cardiovascular disease. And yet here they put it in as well. We just don't know how to use it or what it means. So the problem we've got with statistical methods is we're taking risk predictors for a group and we're trying to apply them to the individual. And so this type of risk profiling is always going to be imperfect. We want to get something that's more accurate that applies to the individual. You don't have a 10 to 20% risk of an MI. You have an MI or you don't have an MI. The problem is people have taken risk factors, they combine them with the lipid profile and try to predict the likelihood of atherosclerosis. Sounds good, but we're kind of forgetting something called genetics. And let's take a look at, I've kind of called this arterial wall factors, and let's talk about that. So here's the arterial wall, and we're going to pull a little piece of that out there. So what's involved with atherosclerosis? Well, number one, entry. These little LDL particles have got to get in the wall. And so endothelial function can affect whether they get in easily or not. But more importantly, if they get in, they can get right back out unless something retains them. And there are proteoglycans, these are proteins that are in the wall there that are secreted that can bind up the LDLs and keep them there. And people secrete different amounts, some are stickier than others. And then, now they're stuck in there, they become oxidized, and oxidation makes them very irritating and sets off the atherosclerotic process. But there's all sorts of factors that affect the likelihood of oxidation. And then we've got the inflammatory response. So once they're oxidized, we set off inflammation. And people have different responses to oxidized LDL. Some people don't respond at all, their plaque doesn't grow, nothing happens. Other people get a significant immune response to this oxidized LDL. It's like putting a splinter under your finger. Sometimes nothing happens. Other times you get this big pus pocket there. Well, that's what happens here. How does the body respond? And everybody's different. That has nothing to do with your lipids, your blood pressure, whether you smoke. All those risk factors that we're trying to predict disease with. And then if you have a chronic inflammatory condition, we know people with lupus, rheumatoid arthritis, psoriatic arthritis, all have increased risk of cardiovascular disease. What does that have to do with their lipids? It has to do with the fact their immune system is upregulated. And so once they see this oxidized LDL, there they go. So you can see we've got all these different things going on here, none of which are really involved in the predictive markers we're looking at. So what can we do instead? Well, instead of using statistic likelihood, why don't we base risk on the presence or absence of subclinical atherosclerosis? Subclinical meaning no symptoms. So what are we talking about? Talking about something called coronary artery calcium scoring or coronary artery calcium. And what exactly is that? Well, it's a CT scan of the heart. And people, when I say that, immediately go, oh my God, catheters and radiation and all this stuff. There's no dye, there's no needles. The horrendous radiation is about the same as a mammogram or less. It takes about 20 to 30 seconds, a couple of heartbeats to do it. And so imagine the heart's a loaf of bread, and the CT scan cuts through this, takes these slices, the heart's a gray shadow, the arteries are gray shadow, but calcium in the arteries are bright white. Now, why would there be calcium there? Because when people put cholesterol in the wall, chemical reactions we talked about go on, and calcium precipitates. And so we'll see calcium there, and the calcium's bright white on the scan. So if we take a look at my example right here, this is a slice, one slice through the heart, and you can see here's the spine back here, here's the sternum, this is the heart in here, here's the aorta, and this is the left main coming off and the left anterior descending artery, and you can see calcification. So what happens then? The computer measures the area density, gives it a score, adds up all the slices, and gives you a total score. So for in this example here, the score is 126. And you go, what the hell does that mean? A high score is 400. So you'd say, well, this isn't a very high score, I'm not too worried, but obviously they're developing disease. But the next thing you want to look at is how do they relate to somebody else, their sex and age? And they go to a table, put in all of that information plus the score, and then it gives them a percentile. Here it's the 84th percentile. This means this individual has more calcium, therefore more cholesterol in their arteries than 84% of people their sex and age. They are loading it in rapidly. Obviously 50% would be their average. 50% have more, 50% have less than they do. But when you hit the 75% marker above, then you're loading it in rapidly. So what this is doing here is it's giving us an idea, a loose idea of volume of plaque, but more importantly, it's giving us the rate that this plaque is developing. Now this is for the individual. There's no statistics involved. It's for the individual. It's what's happening to that person sitting in front of you. And so it allows us then to go ahead and tailor their therapy, their goals, based on what's happening to them. I know they do them up here. I'm not sure what the cost is. We do them in our town for $149. I know I've been up in Oregon, it was $100. In Seattle, it was $100. I kind of have the California mentality. You know, everything happens in California. And I was out in Oklahoma and thought, you know, well, I'm going to unveil this coronary calcium score for them. They're already all doing them out there. They're $100 to get it done. Now, insurance doesn't cover it. The downside, Medicare will cover it if you have 3 diagnoses, but the privates don't. But at $100, $150, it's well worth it, because if it's 0, they don't need treatment unless they have a very high LDL. And if it's elevated, they need treatment. You may have saved their life. Just to show a couple of quick examples here. Just to show you in terms of risk profiling. Again, here's our line of chance. When we go ahead, and the more this moves out this way, the more predictive it is. So if we go ahead and just look at these 1,300 patients here and use Framingham risk, we see where that ends up. If we were to risk profile them with Framingham and coronary calcium score, way out there. So it's much more predictive in terms of patients. Is this something that's recognized? Is this some guy out of Monterey saying, hey, this is a great test? Well, let's take a look at the American Heart and the American College of Cardiology 2010. And basically, they called it a two-ass. I like that. That's what these new recommendations are. It's a 2A classification, which is as high as you can get without doing a randomized trial. And they strongly recommended it for people who Framingham are what we call the intermediate group, the 10 to 20% risk, and that it was still good for people in the 6 to 10%, the low risk group, as a risk profiler. And the International Atherosclerotic Society, in their recent recommendations, 2013, talking about coronary artery calcification, it's a promising approach to profiling, the most widely used, strongly correlated with plaque burden, more predictive than CIMT, and it adds predictive power to that with Framingham risk score. You know, it's easy to treat people's lipids once you know what the risk is, because the rest is cookbook. You only got so many drugs you can use, but you got to know what the risk is. And you want to make sure you don't undertreat or overtreat them in terms of their risk. And that's why I've spent a lot of time talking about risk profiling. Here's a lady we saw recently, a 78-year-old female. She's diabetic, she's hypertensive with a metabolic syndrome. Look at her LDL, 248. Jesus, this lady's walking disease. Coronary calcium score is 0. Okay? She's got tremendous genes. I think another way to think about what I talked about is think of the artery has got a series of doors here that line it. If you've got bad genetics, the doors are open and cholesterol gets in. And how much gets in depends upon how much is in the lumen. But if you've got good genetics, very little doors are open, and even if you have a lot of cholesterol, it's not coming through those doors. So we have to get away from thinking it's all driven by cholesterol. People want to come to me and show me their lipid profile, and they say, what's my risk for vascular disease? I have no idea. What's your genetics? What's your arterial wall like? How easy is it for cholesterol to get in there? So you just can't trust just based on lipids. This is actually the husband of one of my nurses here. And a 47-year-old guy had some very atypical chest pains. These were his risk factors, which were minimal. Here was his lipid profile, which really looks fairly reasonable there. He had a nuclear stress test, which was normal. Now, I wish I had done this, but somebody else did it, and they did a good job. They ordered, we'll get the pooled cohort equation. We used the brand new ones. He's at 4%. You have to be 7.5% or above to be treated. So you wouldn't treat this guy by any stretch of the imagination. But somebody got a coronary calcium score on him. So 493. I told you above 400 is high, and you can see that he's a young guy. So this puts him in the 99th percentile. You can't get any higher. So he is loading stuff in the walls. And if all you did was look at his lipids and his treadmill and then risk profiled him, you'd let this young guy go on to die. Now, of course, he's very young. That's the way I look at it. But let's take a look at a typical scan. So here's the sternum up here. Here's the thoracic spine. We see the ribs coming around. And this is the heart. And you can see this calcification in the left main here. Here's, we're now at another slice. Here's the left anterior descending with calcification. We've got some a little further down, left anterior descending, more calcification. Circumflex has got calcification, right coronary artery. Now those are just some of the shots. And the computer outlines the white areas and gives it a score and adds that up. So again, if it wasn't for calcium score on this individual, we would have missed the boat. So goals of therapy. Let's talk about the goals of therapy with the new recommendations. Again, they only use randomized control data. And the only real good randomized control trials we have are primarily statin trials. So everything is kind of statin-eccentric, statin-centered. And what happened in these statin trials is, if you remember, they didn't say let's drop LDL to a certain goal. They said let's use either a statin dose versus placebo or a high-dose statin, low-dose statin. But it wasn't designed to say, is it better to get LDL to 80, to 70, to 60? So they come out and say, all right, the treatment goals were not designed as LDL or non-HDL as goals, therefore they're not evidence-based. And what is evidence-based is using the amount, the intensity of the statin. If you have vascular disease, using a high-intensity statin in these studies showed benefit. If you had moderate risk for disease, using moderate intensity statin reduced cardiovascular risk. So they have based the treatment goals purely on the intensity of the statin response. So if you're using high intensity, you want to see at least a 50% drop, and they have listed Crestor or atorvastatin as the only two statins that'll do that. Then if you get into the moderate intensity statin, they've got a whole bunch more listed there. Obviously, since the rest of the lipid world lives on LDL and non-HDL, people were a little upset about this. The one other good thing, though, they mentioned was LDL, even down at 70, should be treated in somebody at high risk. And now I hope you understand why. Because if they've got bad genetics, they've got the doors letting the cholesterol in there, it's not the cholesterol that's driving, it's the doors that are the problem. And the cholesterol, the doors are open, so the cholesterol's coming in. And the lower you lower the cholesterol, the less there is to come in. We had a young guy who's 47, had an MI. His baseline LDL was 79. So if you say, well, he's at goal at 70, this guy's not going to do well under your care. You have to realize what you need to do is get the LDL down on this guy. So it's a gradient. It's a gradient. The number of LDL particles in the lumen is what gets into the wall. So you need to reduce that gradient, get those numbers down. So what are the 4 groups that they've recommended? Well, first, we've got the group with clinical atherosclerotic coronary vascular disease. Now, what they've done here is they've not only put in people with coronary disease, people with peripheral artery disease, abdominal aortic aneurysm, but people have had strokes. And this has been added into this group. So our first group here, and notice if a man's under 75 or under, he gets high intensity statin. He would get moderate intensity if he doesn't tolerate the high intensity. Let me take a brief little pause. There is a sheet in front of you that talks about the Lipid Clinic letter. Now, I do this letter, I send it out every 3 months or so, kind of talking about lipids, what's new, what's interesting. One of these was on the guidelines that we're talking about now. So almost everything I'm going to say is in that lipid letter. So if you're interested in getting that, email me to that address, and I'll be happy to send you a copy of that letter and put you on the mailing list. And I promise not to sell your email address, but I will send you lots of spam. So then we've got people who are over 75. They only get moderate intense statin, even though they've got known vascular disease. So why do they get moderate? I mean, so I'm 75, over 75 I get moderate, but I'm 75, I get high intensity. It's because no randomized controlled trials looking at men over 75 getting high intensity statin, they got moderate intensity statins. The next group is people who have an elevated LDL-C of 190 or greater over 21. It's felt these people have familial hypercholesterolemia. They're at high risk, so there's no risk profiling recommended. Rather, they just go on high-intensity statins. Then we've got the diabetics. Now, they were kind of smart here on the diabetics. Diabetics do not all have an equal risk for cardiovascular disease. Some diabetics have no more risk for cardiovascular disease than non-diabetics. And so what they said was, with this realization was, okay, they all go on moderate intensity statin, a 30 to 49% drop in LDL. But since there can be different risk levels, we can go ahead and risk profile them using the pooled cohort equation, which is so accurate. We can go ahead and do that, and if they're over 7.5%, and they almost all will be if they're over 60, then in that case they get a high intensity statin. And then the fourth group is the old primary prevention group. They're not diabetic, they don't have coronary artery disease or vascular disease. They're they're age 40 to 75, and their LDL is 70 to 189. Why is it not 190? Because if it's 190, you move up to that different category and you get treated. So they say evaluate their 10-year risk, and using the new pooled cohort equation, if it's more than 7.5% or more, then they get moderate to high intensity statin. Well, that's a real definitive statement. Moderate to high intensity. They don't go through and clarify who gets moderate, who gets high intensity. And remember, I showed you how many people with their recommendations end up on statins. And that's the people who had the 7.5% or above. Then they talk about saying, well, if you want, the people who are 5 to 7.5%, they could also be added if you want to consider, and they would get moderate therapy. So these are the 4 statin groups here, and that's the recommendations that have come out. What did they say about non-statin use? Basically, no data supporting the routine use of non-statin drugs. And the reason that is because there's very few trials that have really looked at the non-statin drugs. Who to consider for non-statin, what they've said is patients who have high risk, and they're on the maximum tolerated statin, but they get less than the anticipated therapeutic response, less than a 50% drop. These people, they would then consider using non-statins. So people with vascular disease, baseline LDL over 190, diabetes 40 to 75, who couldn't get the anticipated 30 to 49% drop or the greater than 50% drop. And then the group who are completely statin intolerant. Now, just a study that is an old study, which I think is real important, because people think there's this mystique about statins. If they're not on a statin, they're not going to get improvement, dropping their cholesterol. Well, the studies don't really support that. The reason we bought into that is that most of the studies are done with statins. But this was a meta-analysis of 81,000 patients, and they looked at LDL reduction, percentage reduction, and they looked at relative risk reduction. So they're comparing how much if I drop LDL-C, how much do I reduce relative risk reduction here? And what they did was they looked at diet studies, pure diet. They looked at studies that just used bile acid sequestrants. They looked at a surgical study which did partial ileal bypass, which interferes with cholesterol absorption. And then they looked at a bunch of statin trials. And interestingly, when you plot out the benefits of these different mechanisms, they're all in the same line. The bottom line is it doesn't matter how you drop your LDL, you get the same benefit. Now, this is stable vascular disease. In patients who have acute coronary syndrome, there's a significant amount of inflammation involved, and statins are anti-inflammatory and have a role not only for dropping cholesterol, but being anti-inflammatory. But in the chronically treated patients or primary prevention patients, studies do not show much of a role for the pleiotropic benefits of statins. Bottom line, any way you can get the LDL down, it looks like you'll get risk reduction. So concerns about these new recommendations. We talked about the limited data. They dropped LDL-C, non-HDL as targets. They're statin-centric, didn't talk much about non-statins, and they didn't talk about the role of LDL particle number. Now, these are other recommendations for management of lipids. You can see all these different groups here. And in fact, yesterday morning, the National Lipid Association came out with their tentative guidelines. They're going to be out for the public to look at and discuss, and then they'll be finalized in August. So we've got 6 groups that since 2009 have come out with recommendations for lipid-lowering therapy. And this doesn't even count the ACC-AHA we're talking about. How many groups have come out in support or have backed up these new recommendations? And that we don't know if they do or not because they haven't said anything. Europe, Canada, the National Lipid Association, the American Academy of Clinical Endocrinology have all refused to endorse these new recommendations, mainly for the things we've talked about. So is there some way, that rather than wandering in the desert here and having no guidance, we could make some sort of a reasonable compromise on where we should go? Well, let's talk about the first one. This is the people with vascular disease. The problems, the randomized control study, there's no randomized control study that shows that benefit stops after you get a 50% reduction. So why we say we're going to get a 50% reduction and stop, there's no evidence for that. Studies have shown that only 20 to 40% of patients will get their LDLs to goal, under 70, if we're using a drug that just gets a 50% goal. In fact, in a trial that was done here using very high-risk patients, we've got Crestor and Lipitor, and we come over here, 40 milligrams of Crestor, 80 milligrams of Lipitor. These are the percentages that got their LDLs under 70. So 60% couldn't with Crestor alone, 80% with atorvastatin alone. So to think that giving these people one drug, getting a maximum dose, and you're done just isn't realistic. And again, that's why we're having problems people accepting these new recommendations. And then what about the age thing? That over 75, we treat them differently. In a very large meta-analysis, more than 100,000 patients, it didn't matter if the patient was under 75 or over 75. They had similar benefits. So how can we compromise here? Reduce LDL-C by greater than 50% or less than 70. So we've kind of taken recommendations of all these guys and put them together. And the way to look at this is you go what's going to get you lower. So if I'm starting with somebody who has an LDL-C of 75 in vascular disease, I'm going for a 50% drop. Because if I just get them under 70, 5 milligram per deciliter drop, I'm not doing them anything. The more you drop, the more benefit you get. It's been shown by all trials. No hesitation to use non-statins. If you're not getting to goal with your statin, grab the next non-statin, whether it's ezetimibe, niacin, bile acid sequestrants, grab them. And then treatment goals for over 75, you look at the patient himself. You look at his you look at his physiologic age, not his chronological age, to determine how aggressive you're going to be. So what about these guys with the high LDL over 190 and under 21 years? What about them? Well, the assumption is they all have FH, and they all are at high risk, so we have to treat them as aggressively as we can. Well, not all have FH. They don't all have the same risk. They don't all need the same intensity of therapy. So, compromise approach. Yeah, let's go with that 50% reduction and using non-statins if we have to. But once they get to be a male over 40, female over 50, let's reevaluate their risk. Maybe a coronary calcium score. And if the coronary calcium score is very low or 0, we may not have to be as aggressive in terms of medications. Or we might even be more aggressive there. The diabetics. Remember the problem here, how do you determine which are at high risk? Because the pooled cohort equation can overestimate so easily. And we don't have goals, again, here for LDL or LDL particle number. And there's no recommendations for patients over 75. So compromise. Options for estimation of risk. Well, the ACC and American Diabetic Association in 2008 said if you have diabetes, and you have hypertension, or you smoke, or family history of early heart disease, you are high risk and should be aggressively treated. We can use different statistical methods. We can use coronary calcium scores. And you say, coronary calcium score in a diabetic, they're all at increased risk. Well, this was recommended again by ACC-AHA 2010, that it's a way to separate out the high-risk diabetic, the low-risk diabetic. The simple thing to do, treat them all as if they're high risk. Don't bother with this trying to get high and low. You're diabetic. We know that diabetics die. 80% of their mortality is vascular disease. That vascular disease is minimally affected by treating their sugars. You want to treat their blood pressure and their lipids, and that's the best thing you can do for them. So treating them all as if they're high risk is a good way to go. And then the goals are pretty much the ones we've been talking about. For high risk, LDL-C greater than 50 or less than 70. And remember, you take the one that's going to get you lower. So if their LDL is 180, 50% gets them down to 90. Well, 70 is going to get me lower. So in that individual, I want it under 70. But in somebody else, as I said, it was like 120 is their baseline LDL. Getting them under 70 versus the 50% drop, getting them to 60 would make more sense to do the 50% drop. So whatever's going to get you lower. Now what about the big group here of these primary prevention? Well, we know you can overestimate the risk, and everybody's going to be on a statin according to this new guideline. Not clear who gets moderate or high intensity statin, which is a real problem. There's no treatment recommendations for patients over 75 because there's not much data. And then if we go ahead and add this group down here, boy, you're going to have everybody in the world on statins. So, compromise approach. Determine the aggressiveness of therapy. You need to risk profile them, not just with the pooled cohort equation. In the new recommendations, they talk about other factors that can be considered. Family history, that would move them up if it's a positive family history. CRP is up, that would move them higher. They had a calcium score that was elevated, that would move them up. Or an ankle brachial index, that would move them up. Or you can just do a coronary artery calcification, which is what we do, makes it so much easier determining. And then you base your goals on what's up here. And again, it's the same stuff. Under 70 or greater than 50% drop, which is ever going to be lower. And patients over 75, you base it based on their risks. So, notice they've dropped out non-HDL as a therapeutic goal. And if I was to guess, I bet most of you have dropped out non-HDL as one of your therapeutic goals. How many people use non-HDL in trying to get patients to goal? Yep, see, you're right with the new guidelines here, but let's kind of change your mind. I remember, I thought, what the hell is non-HDL? Why would I want to use it? Non-HDL is a surrogate marker for LDL particle number. I know that convinced you right there, but let's go a little further here. When we measure LDL-C, what are we measuring? Well, it's milligrams per deciliter. So a deciliter is 100 cc's of plasma. And what we're measuring here is not the number of LDL particles. We're measuring how much cholesterol is carried by all the LDL particles added up in a deciliter. It's 70 milligrams. So is that 2 LDL particles each carrying 35? Or have I got 10 particles each carrying 7? Or have I got 70 particles each carrying 1? You know, I can go on and on and on. When you look at that, you have no idea how many particles there are. You only know how much cholesterol is being carried in a deciliter. You say, well, who cares about particle number? Well, problem. Atherosclerosis is driven by particle number, not how much cholesterol carried by the particles. It's particle number. LDL-C, it's a surrogate marker for particle number, and it's not a very good one. Non-HDL is a better marker for particle number. If we take a look at LDL particle number and atherosclerosis, it's the number of LDL particles entering the wall is directly related to the number that are in the plasma, gradient driven. This has nothing to do with size. And in fact, we've dropped size. We don't care what their sizes of the LDLs are. It's the number. It's a gradient-driven process, I've said. The more LDLs that get in, the more likely to get trapped, retained, and there we go. So how do we measure LDL particle number? And before I go in here and you're sitting here going, I don't really care about particle number, this guy's from a lipid clinic. Canada, first goal, LDL-C. Second goal, they measure LDL particle number since 2009. Europe, first goal, LDL-C. Second goal since 2011, particle number. The International Atherosclerotic Society, all these groups have recommended particle number. National Lipid Association. So this isn't something that some guy in Monterey with a lipid clinic is doing. The most common one is ApoB, and this is an antigen antibody assay. And just real quickly here, we know the liver takes 5 triglycerides for 1 cholesterol, binds them up into a big particle we call VLDL. And one of the big structural proteins on there is this ApoB100. And as this passes through the capillaries and the fat and muscle, there's an enzyme that starts peeling triglycerides off. It becomes a smaller particle. We take more triglycerides off, and now it's an LDL. So LDL is just a waste product of VLDL. But this ApoB remains with all these particles, so there's 1 ApoB per LDL. Now, when you measure triglycerides on your lipid profile, what are you measuring? You're not measuring the ones here. You're measuring the ones in these particles. So high triglyceride is an increased number of these particles. So that said, let's go on and take a look. If you measured ApoB, each of the LDLs has an ApoB. So that gives you an idea of how many LDL particles. But what's the problem with that? Well, all those particles had ApoB. But the reason LDL works is because the VLDL and the LDL particles only last 4 to 6 hours, where LDL lasts for days. So when you measured 1,000 particles in the blood, 900 to 950 will be LDL. So ApoB is a correlation to LDL particle number. Another way is what we call NMR, nuclear magnetic resonance. You bounce sound waves off the particles and back, and you can get the number of LDLs and the number of HDL particles. ApoB or LDL particle number has been a better predictor because risk correlates, this is for risk prediction initially, it correlates more closely with the number of particles than with the quantity of cholesterol carried by the particles. The amount of cholesterol per LDL particle, if it was constant, then LDL-C would have a constant relationship to LDL particle number. But you can change the amount of cholesterol in an LDL particle 2 to 4-fold. So then you can't trust that as a stable marker for particle number. And then the groups that are going to have the small LDL, think of my example, 2 particles or 10 particles. The group that has the 10 particles are the people who are insulin resistant. The high triglycerides makes the particles smaller, and when they get smaller, they last longer, so that's why you get this increased number there. And these are the most likely to be discordant. So if you see somebody with a high triglyceride, wait a minute, 100's not a high triglyceride. Well, the American Heart Association, American Academy of Clinical Chemistry have defined a normal physiologic triglyceride as under 100. That's not a goal, but that's normal. So if you see somebody with triglycerides over 100, and especially if they have a low HDL, you should immediately suspect that they're insulin resistant, and number 2, that their LDL-C and LDL particle number are not going to be in agreement. So when you treat them, you go ahead, get your LDL-C down where you want it to be, then check the particle number to make sure that's low enough. In a study looking at diabetics who had LDLs under 70, 40% of them had too many LDL particles. And if you realize the statin trials, they prevent 25 to 50% of cardiovascular events, which means 50 to 75 of the events are still occurring on statin-treated patients. And one of the big reasons is felt to be that they still have a lot of LDL particles, and they're not treating those and getting those down because that is what correlates with risk. This is a study looking at Framingham, and there's all sorts of slides like this. But this is probability of event-free survival, years of follow-up. We've got 3,000 patients. This group has a low particle number, and they have both high cholesterol and low cholesterol. But risk follows particle number here. This has a high particle number, and even though they have a group with a low LDL-C, risk follows particle number. And all trials, that's what we see, risk follows particle number. And this is what made the National Lipid Association 2011 come up with their initial clinical evaluation, that part of that should be measuring particle number. Now, what about on treatment? Because we always get this thing, hey, we got the LDL-C to goal, is it good enough? Am I low enough? Well, ApoB is a better predictor. And we'll jump to the bottom here. All statin trials show a significant reduction between on-treatment ApoB and residual risk, but they don't show a significant relationship to on-treatment LDL and risk. It's a better marker for on-therapy risk. Am I at goal? Checking particle number. And that's again why on-treatment management decisions, they use particle number. Now, groups that recommend particle number, we talked about these. Multiple groups have come up with that. Now, what about the other way to measure it? A surrogate marker, since if we don't measure particle number. There really isn't a reason to measure particle number. You'd say, well, a patient can't afford it. Does the patient have insurance? Yeah, they got insurance. Can they afford paying nothing for the test? They can afford that. The labs are out there doing these. Liposcience, Health Diagnostic Lab. These labs, Boston Heart Lab, these labs are taking what insurance pays, and that's it. Patients don't see a bill. So you need to kind of look into this, and costs, I can't afford the cost, the patient can't afford it. It's not a consideration if they've got insurance. So what about this surrogate marker, this non-HDL? What the hell is non-HDL? Well, non-HDL is total cholesterol. Total cholesterol is LDL-C, VLDL-C, HDL-C. So non-HDL means we have eliminated the HDL out of that equation. We subtract HDL from total cholesterol, which leaves us LDL-C and VLDL-C. And so what is VLDL-C? And remember, this is a surrogate marker for particle number. So for getting my non-HDL goal, I know what my LDL goal is. Say it's a vascular guy with vascular disease, it's 70. But what's my VLDL-C? Well, if you remember, I showed you when they make the VLDL particles, for every 5 triglycerides, there's 1 cholesterol. So we go ahead, divide 150 by 5, because that would be what would be normal. That gives me 30. So 30 is the amount of cholesterol in the VLDL. So your non-HDL goal is just LDL-C plus 30. And you think, well, I don't really want to get into this kind of crazy. They're thinking of getting rid of LDL-C in the US because non-HDL is such a better predictor. Europe's definitely talking about eliminating LDL-C. So if you want to hang on to LDL-C as your only goal of therapy, you're going to be left in the dust. Because non-HDL in every trial has shown it's a better predictor of risk because it correlates better with particle number than LDL-C does. So LDL-C is a nice guide to get you in the area, but non-HDL is a better way to go. And look how simple it is. I just take my total cholesterol, subtract HDL, that's the patient's non-HDL. Where do I want his goal? Whatever his LDL-C goal is, plus 30. Another advantage of this is total cholesterol and HDL are not, you can get them with a non-fasting sample. So your patients who have trouble getting their lipids fasting, hey, you don't care. You get a non-fasting. Well, then how am I going to use it? Very simple. Oh. Let's take a patient here, 55-year-old, known coronary disease. Here's his LDL goal. His non-HDL goal, since his LDL goal is under 70, his non-HDL will be 70 plus 30, that's 100. So you put him on a TOR of 40, he comes back, here's his lipid profile. You go, LDL-C looks pretty good. Now, you can stop there, and you're going to have about a 25 to 50% success rate of preventing an event. Or you can say, you know what, I'd like to do a little more aggressive than that. Let's calculate his non-HDL. It's 115. So it's higher than here, so this means what? This means he's got too many atherogenic particles, and what are most of the atherogenic particles? They're LDLs. So this is the guy who, in my example, instead of having 2 particles each carrying 35, he's got 10 each carrying 7. So he's got too many LDL particles, and remember, atherosclerosis, it's particle number driven. Not how much cholesterol is being carried, it's the number of particles. So how do I lower it? And I say, oh, well, look, his triglycerides are up, I'm going to give him a fibrate. Or, gee, I'm going to give him omega-3s. Neither of those lower LDL particle number. The drugs you want to use are the drugs that lower LDL particle number. You bump up your statin. You add azithromycin, niacin. You say, well, niacin doesn't work. Niacin, and this is why you want to get away from looking at through your cholesterol lenses. You know, what's the best drug to raise HDL? It's niacin. What does niacin do? It makes them bigger. So they carry more cholesterol, so HDL-C goes up. It doesn't change the number of HDL particles. And this is why we're trying to get away from this. But what does niacin do? It drops LDL particle number significantly. The National Lipid Association last year said function of niacin is to lower LDL particle number as an add-on to a statin, or in people who can't take statins, then niacin can be a primary drug there. So when you see an elevated non-HDL, boom, I got too many LDL particles. How am I going to lower LDL? One of those 4 drugs. So what about particle size? Because there's labs that will give you all sorts of great stuff on particle size. Well, the National Lipid Association said this is not recommended under any condition because it's particle number, not particle size. And I got big HDL, small HDL. They interchange. You take the small guy, he's antioxidant, anti-inflammatory. He puts a little cholesterol on, now he's a big guy. All HDL particles are good. So problem, particle number is they've not recommended anything for particle number. Statin trials I talked about, their residual risk, and a lot of that's excessive particle number. So measures of LDL particle number are better determinants of on-therapy LDL risk. After LDL is a goal, check to see the LDL particle number is a goal. You can either use non-HDL, ApoB, or LDLP. So guideline summary here, background. The guidelines are not endorsed by many groups. The risk profiling, statistical methods or imaging methods for risk profiling. Goals of therapy, statin dose only or also LDL-C and non-HDL goals. Non-statin use, doesn't matter how you drop your LDL, you reduce risk. Statin groups, they're fairly reasonable, but we need some adjustments. And the reasonable compromise, these new recommendations become reasonable when we blend them with other guidelines, and LDL particle number is in almost every other guideline, should be a target of therapy for us. So there's a lot of guidelines out there, so try not to get tripped up. So thank you.
All right, we got a lot of controversy, and the rest of the day is going to make it even more confusing, I can tell you that. But I'm hoping that when I do my question-answer session, I'm going to simplify all of this stuff. Now guidelines, I know we have to individualize patients. Guidelines are just there to guide us. But the only way we know that 20 milligrams of lisinopril is effective or 25 milligrams of carvedilol is effective in heart failure is through guidelines, through dosages based on studies and guidelines. So I know it's tough, and I know particle number has been an issue, and we know there's a lot of controversy, such as with niacin and AIM-high. And the cost of calcium score in Reading is $225. But I'm not totally convinced about calcium score and HSCRP, because I know Framingham risk is not optimal, doesn't include family history, but if it's a very if your Framingham risk score is less than 10%, there's no need for calcium scoring, and there's no need for CRP, because that patient is very low risk.
There are studies that show between the 6 and the 10%, there is a group that benefits with calcium scoring. But if you're below 5% Framingham, definitely it's not somebody you would risk profile. So you know, it comes down to, if you have access to it and it's reasonable to do, it can make a huge difference in your therapy. Now, I should mention, if you send to me that you want the lipid letter regarding the guidelines, I'll send you some stuff on particle number, non-HDL, how to use that, particle number, what's going on there. So I'll send you a bunch of that stuff.
Time for a question. Go ahead.
So, sorry if I missed it. You listed earlier the groups and how they supported these various guidelines. What about this calcium scoring?
Yeah, calcium scoring is not something they primarily, everybody kind of still uses statistics, but they all have mentioned calcium scoring. American Academy of Clinical Endocrinology, the new National Lipid Association, even these ACC, AHA recommendations talk about calcium scoring as being promising, interesting, and the International Atherosclerotic Society talks about it. So it's where we're moving, because we realize, I tried to show you, risk profiling is just a very inaccurate way. It's great for big groups, but it just doesn't work that well for the individual.
And is that calcium going to stay there? If
Yeah,
you
the calcium,
repeat the test,
the calcium doesn't leave. In the interest of time, I couldn't go into it a lot. But yeah, the calcium stays, and you don't do serial follows.
Okay.
You do it, if it's there, you look at how much it is, and that determines your therapy. If it's 0, recommendation is to repeat it in 5 years, make sure it stayed 0, because you're probably not going to treat them then. So you just want to make sure it stays 0. But if it is positive, there's no reason to do serial ones.
One more question.
That got my question, so thanks.
All right. Thank you, Dr.
All right,
Moran.
thank
Very
you.
great topic. Thank you.